Hello, everyone. Thanks so much for coming to this talk. My name is Grant Comstock. I am a medical toxicologist and am the Associate Medical Director of the Wisconsin Poison Center. And I'm excited to be running through all things envenomations today. We got a lot to go through, so let's go ahead and get started. I have no conflicts of interest. And as a very brief overview with a lot of these talks or a lot of the topics, we'll talk through a little bit of epidemiology, talk more about the mechanisms of toxicity and the clinical presentation, and then the key points to keep in mind for the clinical management of these different envenomations that you may encounter. So, to run through an outline with the big topics that we'll be hitting on in the next 45 minutes or so, we'll start with snakes, then go to spiders, scorpions, and then insects. And you'll notice with the snakes, we have a lot of different genera that are included in here, but we're actually going to lop a couple of these off and really focus our efforts and time on to the crotalids and the elapids, because really, when it comes to North American envenomations, that is the vast majority of what we're encountering. With the spiders specifically, we'll be talking about the Latrodectus and Loxosceles, scorpions, really specifically just the Centauroides, and then finally with insects, Hymenoptera and the fire ants. So to begin with snakes, this is a phylogenetic tree. We will, as I mentioned just a moment ago, be focusing our attention on just a couple of components of this tree. And we'll start with what is easily the most relevant snake envenomation that we will encounter here in North America, be managing through United States poison centers. So we'll start with the crotalids or the pit vipers. And to begin, a little bit about identification of the pit viper, the anatomy of a pit viper, etc. So this is a couple of images of some representative pit vipers, and the main to take a half a step back, if you're not familiar with pit vipers or you don't manage these envenomations very much at your center, the vast majority of what we're talking about are rattlesnakes, North American rattlesnakes. Now, important to say that there are a couple of other non-rattlesnake species that fit in here. Those specifically are the copperhead and the cottonmouth. But again, the vast majority of the species we talk about and the most clinically relevant ones are the rattlesnakes. Their anatomy is distinct. They have these triangular shaped heads. They have these hinged fangs that are on the front, and as you can see on the image in the right, they are pretty impressive. They're lengthy. They're able to penetrate through the skin and the dermis, and able to then therefore inject venom into the prey effectively. They have these. Now, I could not find a great image. This one on the right obscures it a bit, but on the left, you can see they've got these elliptical shaped pupils. And so that's a characteristic manifestation, or sorry, not manifestation, a characteristic feature of their anatomy. And then on the right, you get a better image of these pits, these heat sensing pits. These commonly get mistaken for nostrils. Those are actually up top a bit. These are the heat sensing pits, and it's the pit that is the namesake for the pit viper. So it's a number of some pretty characteristic features that you can see anatomically with the pit viper, and certainly some of these features that are then germane to their ability to produce a pretty significant envenomation, primarily the front and long fangs that are able to effectively inject and deliver venom. A couple of representative examples of different rattlesnakes and different, sorry, more appropriately, different pit vipers. On the top left, you see is the Eastern Diamondback. On the top right is the Mojave Diamondback. Has a couple of pretty interesting and unique features the Mojave does, and so we'll talk about it a little bit later. And then at the bottom are the non-rattlesnake members of the group. It's the cottonmouth on the left, which has that characteristic very white, pale mouth when it opens its mouth impressively like this. And then the copperhead on the right, which has these characteristic brown gold kind of markings, these X-shaped markings across it that give its identity away. So a couple of characteristic or representative members of the group, but certainly there's many more than what's pictured here. And then briefly to expound upon the geography, they're present in quite a bit of the United States. However, there is going to be a geographic distribution for each of the individual species. On the right, those purple markings, those are the copperhead and the cottonmouth. You can see primarily along the southeastern coast and throughout the southeastern part of the country. And then you can see these different distributions for other uh, um, uh, other crotolid species. So on the left, diamondback doesn't specifically denote whether or not that's a western or eastern diamondback. Probably is both, but scattered across the United States Southwest and Southeast. And then the Mojave rattlesnake there along, through Mexico and then through parts of California, Nevada, the United States Southwest. And so each of these species will have a characteristic geographical distribution, and with kind of the variations from species to species, that also informs the geographical variance when it comes to the envenomation that's possible from each of these snakes. So certainly different poison centers will have different takes on the outcomes and then maybe their treatment approach because the geographical distribution of these different snakes, it really again that informs kind of the envenomations that you may see. So what is in the venom that a crotolid is injecting into its prey, into a patient, to a victim? I think the specific enzymes that are present in the venom is probably not particularly high yield. You can see it is just this absolute slew of these different enzymes that include the proteinases, these phospholipases, high alluronidases, and a number of other different enzymes that are relevant to the toxicity. But I think the part that's more relevant is thinking about the clinical effects that are possible from each of these different venom components. And the main ones that we'll talk about, and we'll categorize this here in just a moment, are the local tissue damage, the coagulation effects, and then the neurotoxic or systemic effects that you can see from the venom components that are present. And an interesting piece when you think about we talked a little bit about how the geography plays into the envenomation outcomes and envenomation effects. Different snakes have maybe different venoms, but even within a single rattlesnake, even thinking about just maybe the prairie rattlesnake or the western diamondback, there may be geographical differences, based on their diet, that then lead to changes in the venom components that then lead to changes in the clinical effects that you may see from a victim who's been bitten by that snake. And so that may be very different in Montana, say, as compared to Colorado, even if you're talking about the same rattlesnake. So some really interesting impacts of geography when it comes to the outcome or the effect of the venom. And that can also change year on year, where again the venom components may vary over time, and you can see some differences in the phenotype or the clinical effect that ultimately you're getting when these patients are getting bit. So again, the clinical manifestations, I break it into three broad categories, and we'll dive into each with a bit more granularity here in a moment. But the main ones to keep in mind, and this is really a high yield slide, even if it's got almost nothing on it, is the possibilities for coagulopathy, local tissue injury, and systemic toxicity. And so again, these are the main categories that we think about. It's the presence of these individual kind of features of their toxicity that would maybe prompt you to treat. And so it's really important to have a good sense of these are the ways in which envenomation can cause problems to your patient. And B, thinking about the different specific features and facets of each of these different categories. So let's dive in. We'll start with the local tissue injury. These are some relatively graphic images from patients who have been envenomated by a crotolid, but I think they show some characteristic and important findings. The first is that you can see these hemorrhagic bullae, and these are top left, bottom left, even I suppose the top right, you see these really substantial hemorrhagic bullae where I think because of a combination of factors, it's both the local cytotoxicity, the damage that's being done to the local tissue, as well as the coagulopathy. It's not necessarily they're the two different components of the envenomation, but I think they can both lead to these kind of grisly looking pictures where you have just these really profound looking hemorrhagic injuries, hemorrhagic bullae, things like that. These would be particularly concerning findings. Each of these, top three, or the top two, I suppose, in this bottom left, for different reasons. The first is you look at this top left image. These are some really profound bullae that are affecting and looks like maybe even circumferential on the digit. So really has a high chance of leading to substantial tissue loss. And when you talk about a digit, you talk about a hand, you're talking about really substantial loss of function. So this is a really important, I think very obviously, envenomation and one that would prompt some really aggressive care. Same thing really on the top right. You can see that this one has already been opened. General teaching is you never want to pop these bullae. They'll break themselves, but while they're there, they're a good biological dressing, so you leave them intact. But certainly again a pretty important finding. The next one down here on the bottom left, you can see that this one crosses a joint, and that commonly is used as kind of a barometer of saying, oh, this is a substantial local tissue injury. This is a local tissue injury that is now crossing a joint. We don't have any what we'd call local control. Perhaps we need to be thinking about giving something like antivenom to a person like this. And then on the bottom right, frankly, this is probably a more typical finding, but just the lack of these really substantial findings on the bottom right do not necessarily tell you the whole story. You can absolutely be dealing with some substantial underlying tissue injury, even if you aren't seeing these really devastating looking hemorrhagic abnormalities that you're seeing there on those other three images. And so another feature that you want to keep in mind when you're evaluating for local tissue injury is not just the gross appearance of that wound, not just the degree of swelling. Those are things that we follow. We'll potentially follow, like limb circumference. If it's an area that's been envenomated, you can look and say, day one it was 18 centimeters, day two it was 25 centimeters. Perhaps it's a sign that the edema and the swelling is getting worse. But really, what could be actually a more effective and sensitive measure for the progression of local injury is the leading edge of pain. And so, in this person's foot, you wouldn't necessarily know exactly where the local tissue injury stops. But what you can do is just on serially, when you're measuring for evidence of progressive injury, you can just find that leading edge of pain. You mark that spot and you say, is that spot, is that progressing further up the limb? Am I dealing with additional or progressive tissue injury? And that can be really helpful and maybe give you a sign that tissue injury is progressing, even if you aren't looking at these more grisly manifestations of more substantial wounds. So they don't all have to look quite this grisly. They usually don't, frankly, but that's not necessarily an indicator that all is well. The next is a bit more straightforward, is these hematologic effects, and really they are species and geography dependent. In the United States, generally speaking, we are coagulopathic that we're going to see as compared to hypercoagulable. But certainly you can see some features that are consistent with things like a consumptive coagulopathy, things like DIC, where you have those substantial drops in platelets, drops in fibrinogen. You've got clots forming somewhere, and that ultimately leaves you susceptible to being unable to clot when you need it. And so you could also see, this rise in PT and INR. And so these coagulopathies are a really important manifestation. And especially for the more coagulopathic snakes, can really be a primary driver for morbidity and mortality. So important things to monitor. And if you have somebody who's got a potential envenomation, you certainly want to be checking in on those coagulation parameters often, and seeing which way you're going. The other thing to keep in mind is that these may persist even if you've obtained local control, or some of those other more local injuries or systemic symptoms may be improving. These hematologic effects can persist, and it leads to some clinical controversy about what to do with it. Ultimately, what we found is certainly early, if somebody goes and develops a trauma, right after they've had a major envenomation and they're coagulopathic, of course, they're at risk for bleeding. And like I mentioned, bleeding is certainly a major cause for morbidity and mortality, or can be. But when it persists and you have somebody who's persistently a little thrombocytopenic, the INR has not come back to normal, uh, days or even a week or more after their envenomation, it's challenging to know exactly what to do with that. There are some folks who would advocate for additional antivenom and continued treatment, and those who would say, look, the majority of our data and experience would suggest that these aren't patients who bleed a ton as long as they're not doing particularly high risk activities. And so there are those who would say, yes, these findings may persist, but ultimately it's not clinically terribly relevant, so we leave them alone. So a bit more controversial on what to do with the back end of these hematologic abnormalities. And then the last one is, it's a really quite a broad bucket, is this systemic toxicity. You can see, a host of different organ systems getting involved, from gastrointestinal. You can see nausea and vomiting. Interestingly, diarrhea has actually been pulled out in a couple of different studies as a marker for more significant, clinically significant toxicity. And so if somebody's got really, substantial diarrhea after an envenomation, that should make the hair rise in the back of your neck because it's maybe somebody who's about to develop some more major and progressive systemic symptoms. There are these non-specific neurological manifestations. We'll talk about a couple of others here in just a moment with one specific toxin. But there's this non-specific metallic taste, weakness, things that folks can present with. There's one really interesting one called myokymia, which is this rippling like movement in the skin. It's like the twitching in your eye that is ocular myokymia, if that's any kind of reference point. And I don't know if it's completely specific to the rattler, but the timber rattler is kind of notorious as having the myokymia as one of its clinical manifestations. And then there are the major life threats that we think about for the systemic toxicity. And certainly there can be a component of just pure plain old anaphylaxis and angioedema. Sometimes it's a little hard to parse out whether or not angioedema is a manifestation of anaphylaxis or if it's a true venom effect. And that's something that just takes, I think, a lot of consideration, for lack of a better description. But it can be hard to differentiate between those things. And then you can see just full on hemodynamic collapse. So major, tachycardia, tachyarrhythmias, and ultimately hypotension and hemodynamic compromise. And again, that would obviously be another one of the major reasons or ways in which patients can succumb to their envenomation. Another one that gets a special shout out is these neurological effects. And granted, neurological effects are included amongst those systemic effects that I just mentioned. However, there is one specific toxin that's present in the Mojave rattlesnake or Crotalus scutellatus. That is the Mojave toxin. It is primarily a phospholipase A2. It acts at the presynaptic neuron at the neuromuscular junction and thereby blocks acetylcholine release. And if you're not getting acetylcholine release at the neuromuscular junction, that's not great because that is how we fire our muscles. And so you wind up with muscular weakness, cranial nerve dysfunction, and most ominously, respiratory paralysis. So a major and important one to be aware of, as it does have a bit of a different manifestation than a lot of the other crotalid toxins and envenomations. So not all bites are quite so bad. About 20% of all bites are dry bites, and that just means that, perhaps they did get bit, you see some fang marks, etc. But they never develop any local symptoms, systemic symptoms, coagulopathy, etc. And we can come up with, find out which of the patients are going to be dry bites within 8 to 12 hours. You should start to see manifestations of their envenomation within an 8 to 12 hour time frame. And so depending on your poison center and hospital's protocol, after that period of time has elapsed, you can say, yep, dry bite, this person can go home with no, or additional monitoring or follow-up indicated. So let's say you get one of these calls to the poison center. Somebody has just been bit. They aren't yet demonstrating any symptoms. What do we have them do? Well, the first is please have them not collect the snake. That is an unfortunate instinct amongst some victims, is to say it's going to be really helpful to bring this snake into the hospital because that way they can treat me more effectively. The reality is we do pretty much the same thing for anybody who has a potentially meaningful envenomation, especially in North America. It's usually pretty straightforward unless we're talking about an exotic snake. So having that visual identification is very much not a necessary piece, and it's certainly not worth the risk of them getting envenomated a second time. The next one I think is an important one, where we talk about removing restricting things or constrictive things near the bite, so watches, jewelry, etc. And the primary reason to think of that is that the primary toxicity of a rattlesnake or a crotalid envenomation is that local tissue injury, is that myotoxicity. And so if you're starting to develop a lot of swelling in the area, well, the last thing you want is a bunch of constricting things around there. And to that end, and we'll talk about the don'ts of first aid here in a second, you also don't want to be doing things like putting a tourniquet on. Because yes, that will keep the venom from getting systemic, but it will also substantially worsen the local tissue injury that's potentially getting started with that envenomation. And so you do not, especially when you're talking about a rattlesnake or a crotalid envenomation, you do not want to be restricting the blood flow or having any constrictive devices present. And then, of course, you want to find a safe way for them to exit their situation and seek medical care. This is the slide I mentioned. This is the don'ts of snakebite first aid. There's a lot of funny things that are out there on the market, or I suppose would be funny if people weren't actually trying to sell this for medical purpose. The one on the left is this extractor, and there's a really there's a pretty funny article that was published now many years ago that says it's something. The title is something to the effect of "The extractor does not suck venom; it just sucks," or something to that effect, because it's got demonstrated complete lack of utility. It does not effectively extract venom. It is not worth anybody's time or money. We also want to advise people to not try to do really heroic things to try to get the venom out. You don't want them using a blade. You don't want them trying to suck the venom out. People will use like electrocution. That's like a taser there on the bottom right, and to try to mobilize the venom out of the wound. Obviously, that's not indicated. And then, as I mentioned on the prior slide, you don't want to use a tourniquet or any other kind of restrictive devices, specifically when you're thinking about a rattlesnake envenomation. Tourniquets are a no-no for all of these envenomations, but no constrictive devices at all are indicated for the rattlesnakes. So, what are the do's then of caring for these patients? So, we've got the patient to the healthcare facility where I point all of my residents and early fellows when they're thinking about how to advise about an envenomation is the unified, rattlesnake treatment algorithm that was published by Lavonis in their work group back in 2011. It's quite straightforward. It's really sensible, and it's held up quite well for the last 15 or however many years. And so it starts by looking for those signs of envenomation. So we've assessed our patient, we've done wound care, we washed the wound, we updated tetanus. We're not giving antibiotics. There's no indication for prophylactic antibiotics. And then we're looking for those signs of envenomation, and that's marking that area, looking for the leading edge of pain. That's when we're checking our coagulation indices and we're thinking about and asking the right questions to get a sense as to whether or not they have systemic toxicity. If they are showing evidence of a meaningful coagulopathy, if they're showing clinically important systemic features, those are patients that'll go ahead and get treated right away with an antivenom. And we'll talk about that here in about 3 seconds. Um, if they have just a small amount of local tissue injury, a lot of times we'll recommend just observing those patients. And if it's not expanding, if it's not progressing, it's not looking like it's a major wound, then you kind of leave it alone and you're just watching to ensure stability. If it's progressing or it's starting to, cross major joints, or it's on a really clinically important area, like on a digit or something like that, then we're thinking, hey, this is a really important area that is, or maybe even a spreading area that's now getting involved. Let's think about antivenom. So the same thing. That's when we're talking about giving an antivenom. So let's talk then about antivenom. In North America, we have two major players as far as antivenom goes. On the left is the older of the two, it's Crofab, and on the right is Anavip, which is considerably newer than Crofab, and with some proponents as to some potential advantages, but controversial. So, what are the difference between these? Well, all of these start with whole IgG. And these are antibodies that are developed in some host organism. So for Crofab, it's developed in sheep. In Anavip, it's developed in horses. And those sheep or horses will be injected with some cocktail of different snake venoms, and they very kindly then produce their own immunological response, and that entails the production of a lot of these whole IgGs. Those whole IgGs then undergo some additional processing with the goal to be to get rid of this non-binding FC region of the immunoglobulin. And the reason why we do that is it is terribly immunogenic. This is one of the main reasons why people develop things like anaphylaxis, serum sickness, all that kind of stuff. So removing this is highly advantageous in making it a more tolerable drug to our patient. Now, depending on where you cleave, so again, we've cleaved this part, but depending on where you cleave, if you cleave right here at this spot, kind of on the left or the right, you're left with just this Fab component, and that Fab is Crofab. And if you cleave down lower and you keep these two ends kind of intact, then you wind up with a Fab2 fragment, and that's what Anavip is. It's a Fab2. The main difference when you're talking about a Fab versus a Fab2 is, well, Fab2 is about twice as big, as you can see by this simplistic schematic. And because it's so big, it takes a lot longer for the body to get rid of it. So the half-life is about 5.5 days for Anavip as compared to a half a day or a day for Crofab. You can look through the dosing regimen. You know, you have your initial dose, you have maintenance dosing as needed. Some will do standardized maintenance dosing for CroFab. Some will just do it as needed, and then the Anavip has just its as needed maintenance dosing, and they have a very similar adverse effect profile. You can think of, you know, as long as you've gotten that FC region out of there, you're going to have ultimately a pretty similar reaction to the medication. The main difference and the main reason why some have become advocates for Fab 2 as compared to Fab is because it lasts so much longer. The um, purported benefit is that it's then a better match to the duration of action of the venom. And so you're not going to have delayed symptoms, delayed coagulopathy, other problems like that. And so that is why some will use Anavip to Crofab, but frankly, they're both effective in managing those manifestations of a rattlesnake envenomation, and both are very much standard of care. And so you're going to find different hospitals that stock different ones. It's not worth keeping you up at night as to which one of these two are getting used because they're both effective options. So I think that is more probably than enough said about crotolid envenomations. And with that, let's move on to our next group, which will be the elapids. There are lots and lots of clinically relevant elapids out in the world, but again, we're taking a very myopic North American view on all of these issues, and so we're going to look really specifically at the Micrurus genus, and that is coral snakes. So coral snakes are really geographically much less broadly distributed in the United States. They're kind of right along the southeastern United States, often in Florida, Alabama, Mississippi is where you're going to see the majority of these. There are a couple of species in Florida. There's the eastern coral snake. When you get to Texas, there's a Texan coral snake, which seemingly does not have quite the same severity of toxicity or of the envenomation is not as clinically severe. And then there's also a Sonoran rattlesnake out west, and from my understanding, that actually lacks any potential for envenomation at all, or for major clinically relevant toxicity. So not one that we treat or that we worry about. But it's really the eastern coral snake that gets the majority of the attention when it comes to the North American coral snakes. Uh, there is a look-alike for the coral snake. It's the king snake, and there are these old idioms as far as how you can kind of differentiate between one and the other. So on the left is the coral snake, and the saying is "red on yellow, kill a fellow," and it's because the red touches these yellow bands. And so, and that is a differentiating feature as compared to the king snake, where the black separates the red and the yellow glands. So red on black venom lac, that would be a king snake. I personally am not brave enough to have any interest in getting close enough to try to discern between the two. And if I saw this general pattern, I'd probably keep my distance. But that is the old adage. These are not nearly as much of a part of uh, our burden of disease, I suppose, for snake envenomations in North America. They are responsible for about 2% of all snake bite calls to United States poison centers. And that's a couple of reasons that come into that. One is they're not as widely distributed. The other is the anatomy of their fangs. So these are small fangs that don't necessarily have the capability of penetrating or puncturing skin. It would be good for a small rodent or things like that, but when it comes to a human, they aren't necessarily going to have the capability of delivering venom between the small fangs and the small mouth. It makes it hard for them to deliver the venom. So the chance of becoming clinically in a meaningful way envenomated is less likely. That said, when they do envenomate, it's a real problem. So instead of those kind of three categories of toxicity that we talked about with the crotolid envenomations, these are primarily neurotoxic snakes. They contain these alpha neurotoxins, and the way they work is that they bind and then competitively block the postsynaptic acetylcholine receptors at the neuromuscular junction. And again, I think it's probably pretty straightforward why that is so problematic. If you block the delivery, or sorry, if you block the binding of acetylcholine to your receptor at the NMJ, then you can't fire your muscle. And so in patients, the clinical presentation of this is that there is an asymptomatic period, but then in patients who develop meaningful symptoms, they start to develop paresthesias, slurred speech. And then the really concerning ones is when you start to develop bulbar weakness, so facial weakness, neck weakness, things like that, cranial nerve dysfunction, and then a descending paralysis with respiratory failure being the feared ultimate outcome for this. That asymptomatic period up to 13 hours is really, really important that we aren't writing these patients off too soon. We'll talk about it in a moment when we talk about the management strategy, but it is absolutely imperative that anybody who has a potential for a coral snake envenomation, that they have a prolonged observation period before we say that they're okay to go home. So a day of observation in a place that can care for them if they start to develop severe manifestations. Now, this is a major difference as far as the earlier or the first aid care of coral snakes as compared to what we just talked about with crotalids. We don't use tourniquets. However, this pressure immobilization bandage is something that's indicated for a coral snake envenomation. I have been told by people who know more about snakes and think more about snakes than I do that these are almost never applied correctly. I can't verify whether or not that's true, but I take that to mean that they're not exactly straightforward to put on. But to my mind is basically a progressive pressure wrap starting distally, moving proximally, and covering both below and above the site of envenomation. This is not something I've ever done clinically because I've never taken care of a coral snake envenomation clinically, but it's certainly something that is talked about with coral snakes. But the absolute key to this is to recognize that this is a strategy that is specific to the neurotoxic envenomations like coral snakes and is not for ones that are myotoxic, the ones that are going to cause that local tissue injury. This would be an absolute no-no for those. So do not do this for the pit vipers, the crotalids, the rattlesnakes that that is going to worsen their envenomation. So an important thing to distinguish. So then, how do we manage a coral snake envenomation? The first is just good supportive critical care capabilities. Patients who have a real probability of having been envenomated by a coral snake should not be watched in, a very outlying hospital without critical care capabilities. That would be the wrong place for them to be taken care of. They should be watched in a care facility that has the capabilities of managing their airway, managing their ventilatory status. And so critical care capabilities are a must when you're talking about the facility who's going to be caring for these patients. And all of these patients need an observation period of 24 hours in this type of environment. So no, these patients should not be getting dispositioned from a healthcare facility too early, or else you have the potential to miss a very devastating envenomation with delayed effects. Beyond those basic, wound care, critical care, supportive care type of measures, there is an antivenom that is available for coral snake envenomations. Now, we talked about how the crotalid antivenoms are those fab fragments, the fab or fab 2, depending on whether or not you're talking about crofab or anivib. The North American coral snake antivenin, or NAXA, which I don't know if anybody calls it that, but I'm going to. This is a whole IgG, and so potentially you would be looking at a higher risk for the development of things like anaphylaxis, serum sickness, things like that. Um, who do we give this to? Apparently, once upon a time, we were giving it to anybody with a possible coral snake exposure. That has been studied, looking at the role of prophylactic treatment, and ultimately, in broad application, there was no benefit found. So really, anybody who's got any symptoms from a coral snake envenomation, you don't need to wait until they're paralyzed. You don't need to wait until they can't breathe. If you are starting to develop major paresthesias, any sort of weakness, cranial nerve dysfunction, you have it, or you name it, I would go ahead and start treating with the antivenom. This is not also going to be nearly as widely available as the crotalid antivenoms, and so one of those things, if you're really thinking about it, that this is going to be a possibility, is to start um, uh, engaging with whatever partners you work with at your poison center to be thinking about antivenom acquisition. And we really do end with that, with the snake envenomations, because between the crotalids and the coral snakes, that is just the absolute vast majority of what we're going to be seeing in North America. It skips so many really important and really fascinating envenomations because the majority of clinically relevant envenomations are not happening in North America. So a lot of the Viperinae that you see down there on the bottom right, there's an enormous amount of diversity, complexity, severity of illness that are seen globally, but we won't touch on it because it really isn't the North American pathology unless you're talking about exotic snakes, which is, a continued issue, something that we certainly see, but it's one of those that you kind of take one at a time more than in a systematic way. I will say that the colubrids, we certainly have colubridae here in North America, but broadly speaking, we talk about them in the United States being non-venomous because they are rear-fanged and so unable to effectively deliver venom. However, there are some colubrids that are present internationally. One that comes to mind is the African boomslang. And there's a sad story from now the better part of a century ago where a herpetologist in Illinois was working with a boomslang, was convinced because it was a colubrid that it was that it did not have a clinically relevant envenomation or that it could not envenomate him. He was handling it inappropriately. He was bit, and he actually died from the coagulopathy from his envenomation. So there are some clinical relevances here, but not in the broad way in which we would want to talk about it systematically, like the crotalids and like the coral snakes. So with that, let's move on from the snakes to the spiders. And if anybody has any phobias of snakes and spiders, I am deeply sorry for your having to deal with this PowerPoint because it is it's a lot of pictures. So, but anyways, we'll push forward in spite of any phobias that may exist. So the first spider and the most relevant, I think, spider when it comes to North American spider envenomations is Latrodectus species, and the one that we talk about the most, the one that's most relevant here, is Latrodectus mactans. That's a black widow. It's got a couple of very characteristic physical features. It's got that red hourglass shape that's very pretty and scary looking on its ventral surface on its abdomen. The females are bigger than the males and reportedly are more effective at envenomating than their male counterparts because of their ability to, with their larger fangs, ability to penetrate the skin and deliver the venom. Um, these are present geographically, functionally everywhere in the United States, every state except for Alaska, but certainly there are some regions that have more than others. I'm in Wisconsin currently, where I've yet to encounter a Latrodectus envenomation, but I trained in Colorado where we had a single season where I think I clinically took care of 9 at bedside, and so there's definitely some variability. Um, they usually have these large, untidy, kind of scraggly webs, and they tend to live in dark spaces, in sheds, barns, under log piles, and things like that. So, how does their envenomation work? The toxin, the venom that is responsible for the clinical manifestations of a black widow envenomation is this alpha latrotoxin. And it works in a pretty cool way. I learned some things about this as I was putting these slides together. So, alpha latrotoxin, it starts kind of at the top of the screen. It initially needs to be activated, and my understanding is that's activated in the venom gland, the bulb, upon delivery. And so that activation leaves you with this like monomer that eventually will form a tetramer when it interacts with a receptor that's on the outside of a cell membrane. And when the monomers then form a group of four, a tetramer. Ultimately, what that leads to is the ability to kind of bore down into the cell membrane and produce these non-specific cation ionophores. So these holes functionally in the cell membrane that allow free passage of calcium, sodium, etc. And ultimately, what that leads to is once you've got that hole in the cell membrane and you're allowing for calcium to be able to freely pass from extra to intracellular, you allow for the delivery of calcium into the cell, and that influx of calcium into the cell is a key step in the release of a lot of neurotransmitters. It's actually the last stage and really a lot functionally most, if not all, vesicle release. And so if you're at a catecholinergic neuron junction, what ultimately you can have is this influx of calcium leading to the release of or the delivery of a lot of catecholamines, so epinephrine, norepinephrine, etc. And so the short of this is that alpha latrotoxin is responsible for the non-specific release of catecholamines in a local setting, so in the area around that wound. What does this look like? I include this picture because it is so underwhelming looking. This looks to me like nothing, and I'm sure cruise right past it on a physical exam. There, you might see some injection points. You might see one, you might see none. All of them are possible. There's one really, I think, important and unique clinical finding that I learned when I learned about these, taking care of these at bedside, is the presence or the possibility for local diaphoresis. You think about that. potential for a lot of local catecholamine release, what you can wind up with then is not my whole body is sweaty, but I'm really sweaty right around this wound. And so if we were thinking about this being a Black Widow envenomation, one thing that we would do is just rub our hand across the skin or across that wound and see does it kind of stick right at that spot, and that's a sign that there's some local sweating. And can say clinically, I've actually seen that happen a couple of times, which is pretty fascinating. What does it look like clinically? Well, early on, it's local and severe pain. And when I say severe, I mean severe. These people look absolutely miserable, and the pain can be quite intense. As time progresses, it can improve or it can progress into these painful cramping, really severe muscle fasciculations. And that's the cutaneous manifestations. That's the pain component of it. And that really is a large component of what these patients come in with. Um, there are some other manifestations that can occur. You can see some cardiovascular manifestations that I think about the physiology or the pathophysiology of this envenomation. It's catecholamine mediated. So it's really a lot of tachycardia followed by bradycardia as they get potentially more ill. It mentions hypotension followed by hypertension. When I've seen these patients, it's really been a lot of hypertension. I think a mix of mediation from pain and from the catecholamines that they're releasing. From the GI perspective, you can see nausea and vomiting. And then it's an important thing to recognize that these can come in as mimics. So, as a couple of examples, I've taken care of a 4-year-old child who couldn't very in detail express what had happened to them, but they were bitten on the abdomen, and because their bite was in the right lower quadrant, they had a full workup for appendicitis, including a CT scan, until somebody got a bit more history or some other history came out, and we found the area of envenomation, treated them, and realized that a lot of that workup had been all for naught. And so it can, depending on what is bit or the area of envenomation, you can see these different mimics because they are in considerable pain. And if you don't recognize that it started with a bite, it's easy to start working up other potential pathologies. The duration of this, it can be a half a day, it can be multiple days. And I've seen it, again, anecdotally last even longer than this. And so people can be in some agony and some misery for some time. We tend to grade these to try to give us a sense of how severe they are. Grade one, we're talking really not severe symptoms or just local pain, but normal vital signs. Grade two, we're then talking about some symptoms that have moved beyond the local envenomation. That's when you start to also see the local diaphoresis, but still vitally they are normal. And then grade three are those who are more systemically ill with the diffuse diaphoresis, abnormal vitals, and then also with the severe pain. Supportive care, a strong argument could be made that what is on the slide right now is the entirety of the care that's indicated for a Black Widow envenomation. For grade ones, you can give them NSAIDs if they need it for pain, ice packs for pain, but you shouldn't need to move beyond that. And then for grades two and three, it's IV analgesics, so IV benzodiazepines, IV opioids are going to be the things that people primarily lean into for pain and symptom control. However, there is also a latrodectus antivenom. This also is a whole IgG. It is horse or equine derived. And it's controversial. And it's controversial because there is an adage that would say that because this is a whole IgG antivenom, it runs the risk of severe serum sickness or, more concerningly, anaphylaxis. And with anaphylaxis, of course, there is a not zero chance of dying. And we would use this to treat what is broadly, I think, agreed upon as being a non-fatal envenomation. So we're using an antivenom that carries a risk of fatality to treat a potentially non-fatal envenomation. And because of that kind of mismatch, a lot of people will say there is no role for the antivenom in the treatment of a Black Widow envenomation. I am not in that camp. I've taken care of enough of these at bedside and seen the agony and the misery of these patients that my hope would be to offer them any intervention that I think is reasonable and safe. And there's a multiple, I think, points that to my mind make this not an unreasonable intervention. One is that risk of anaphylaxis is, to my understanding, a bit overstated and not terribly common. We have ways in which we can try at least to identify those who are going to be at higher risk for developing a significant allergic or anaphylactic response. And then, of course, they're always going to be in a monitored setting. And so if they do start to develop clinically significant allergic symptoms or anaphylactic symptoms, that's treatable at the bedside. And I'll say that even though this is not necessarily a fatal envenomation, there is substantial morbidity. These patients are in agony. It's potentially days. And so for those who are left with just parenteral symptomatic control only, I do think to leave them without what is a potentially viable treatment adjunct or option, that's not my approach. So I'm a proponent of using this, but I certainly do recognize the clinical controversy, and you may encounter some of that controversy in your centers when you think about this. So moving on from the Black Widow to the other one of the most, or I'd say the other most relevant spider envenomation in North America is the Loxosceles reclusa or the brown recluse. The brown recluse also has a kind of some characteristic physical or anatomical features, and the main one that we talk about is on the dorsal aspect is this violin-shaped marking that I always have unless it's pointed out specifically, I have a little bit of a harder time identifying than I do, say, the hourglass and the Black Widow. But certainly once it's pointed out, I think it's fairly notable. It's got certainly a more limited geographical distribution than does the Black Widow. The majority of these brown recluses, where you'll see them, is in the southern and kind of central parts of the country. So the southeastern United States and the central United States is where you're going to see the majority of these envenomations. There are other species that are dotted throughout the Southwest. My understanding is that these different species are less clinically relevant because they have less severe envenomations. And so it's really that kind of central and southeastern region that has the most clinically relevant envenomations when it comes to brown recluse. The mechanism of toxicity, this is really a locally cytotoxic envenomation. So it's sphingomyelinase D that causes local tissue injury and this local cytotoxicity. The clinical manifestations, it starts with just a painless, lesion, painless wound, erythema, edema, and then that ultimately over time progresses. And I've got some other images on the next slide, but progresses to these other kind of characteristic looking wounds that can be painful, they can be ulcerative, and they can have some really difficult times healing. It is common to see people come into emergency departments with concern that they have a loxosceles or really, frankly, any spider bite. The vast majority of those wounds are not spider envenomations. I don't think that's surprising probably to anybody who's listening to this presentation. The majority of those are infectious, MRSA, etc. But there are some tools that are available on different publications that can help you to distinguish between what may be a loxosceles envenomation as compared to just something like a MRSA or an abscess or some cellulitis. One that I really like is the mnemonic not reclusa, where letter by letter it runs through some characteristic features of one versus the other. And then over time, these can develop into eschars and some wounds that need some longer term wound care. Important to realize, though, that there are certain patients in certain scenarios in which it's not limited to just these local cutaneous lesions or cutaneous wounds. Primarily, you see this in pediatric patients, but you can see some hemolytic and hematologic, manifestations as well. Things like methemoglobin, hemolysis, DIC, thrombocytopenia, etc. So important to keep in mind, it may be more than just what you're looking at with your eyes there on the skin. A couple more images that kind of look at the progression of these wounds. On the left, this is a pediatric patient, I believe age 3, that was published in the New England Journal, and on the right, a wound that was published in the Lancet. This one on the left, I think, is helpful because you can see just how severe some of these wounds can be and how refractory to healing, even in a young patient who presumably has good healing potential. The healing can be problematic. And then on the right, this is kind of a characteristic look at the features of this wound, and I have it on this one as well. There's this central darkness followed by kind of a ring of kind of white or pallor, this kind of clearing, and then on the outside this red, and people will call this the red, white, and blue lesion. And what that red, white, and blue represents is erythema, so a lot of inflammation on the outside, ischemia in that middle part, and then thrombosis in the middle. And I think this is a more stark example of that same lesion pattern in somebody who clearly has progressed a little further there on the right. So important to recognize that you can't just stop with the dermatologic evaluation of these patients. These patients, if you're looking at a characteristic lesion, if you've got a positive identification of a spider, if you've got for whatever reason a strong suspicion that you're looking at a brown recluse envenomation, you should be getting a CBC and a BMP to look for signs of hemolysis, to be looking for signs of kidney injury, and if you're seeing hemolysis, then further working that up to see what the severity of that looks like. Because that can be quite severe, especially in pediatric populations. So you don't want to cruise right past that. And then how do you manage these patients? Well, the vast majority of these, it's going to be symptomatic care, wound care, etc. Anybody who's developing systemic symptoms, showing signs of hemolysis, renal injury, obviously if they've got DIC, they need to be admitted to the hospital and receive supportive care for those manifestations, but transfusions or whatever else they may need. It's standard wound care measures for the wounds themselves. You don't want to try early debriding. You don't want to. There's no really role for prophylactic antibiotics. It's really just standard good wound care, keeping it clean, and allowing for wound healing as best you can. And for those like on that image on the prior slide that are dealing with prolonged poor wound healing, some of these do eventually need debridement and grafting, but only after a trial of attempting to heal spontaneously. And then the only thing that I would offer is antidotal care, I think says it too strongly, but there is some mixed evidence about the effectiveness of using dapsone for some of these necrotic ulcers, that red, white, and blue pattern wound. Some will advocate for the use of dapsone, but the evidence for its effectiveness is mixed. So moving along to our next category, we're onto the scorpions. So in the United States, the main one we're talking about is Centroides sculpturatus. Um, the the hang up that is sorry, the hang up that we commonly hear when somebody is first talking about or dealing with scorpion envenomations, if they still talk about the bite. There's no bite when talking about the scorpion envenomations. These are now stings. And the stings come from this back end where you can see there's this bulbous area there at the very end of their tail, and that's called the telson. And then from the telson comes the stinger, and that's where their venom is stored in the telson and delivered through the stinger. How does that venom then work? Well, it is a sodium channel opener, and that results really in the uncontrolled release of acetylcholine, both from the NMJ and parasympathetic nerves. So you have a significant muscular response, a parasympathetic response, but also the release of a substantial amount of catecholamines. So a sympathetic response. So you've got this weird toxic blend of release of these catecholamines and neurotransmitters that lead to some pretty impressive clinical manifestations. Three specific kind of categories that we think about is we'll start with kind of going one by one. So start with the adrenergic excess. The main way you're going to see this manifesting in your patients is with vital sign derangements. So unsurprisingly, tachycardia, hypertension is common, but you can also see things like agitation, irritability. In more severe envenomations, you can see seizures. And also reports of myocarditis from that substantial exposure to supraphysiologic loads of catecholamines. From the acetylcholine release from parasympathetic nerve endings, you get that cholinergic excess. And so again, it's fascinating that some of these are kind of counterpoints to the other. So instead of the tachycardia that you see with the adrenergic excess, you can see bradycardia and some vasodilation. But more prominently, what you're going to see clinically is the vomiting, is these sludgy type of symptoms. So the vomiting, the diaphoresis, salivation, meiosis, etc. And then they can have substantial amounts of secretions as well, bronchiosecretions, bronchospasm. A lot of the other, I mean, these are the things that you talk about with nerve agents, organophosphates. It's a lot of those same manifestations that you can see. And then the last is this neuromuscular excitability, which is a manifestation of having too much acetylcholine released from the NMJ. And so you can see these really challenging to manage and these really painful and miserable looking muscular tone related issues where it can be muscle spasms, it can be facial grimacing. You can see opisthotonus where you have contraction of all of your extensor muscles in your body. And so that's the back arching type of look. Which is a terribly unpleasant, morbid, and actually carries some life-threatening components to it as well. And then with uncoordinated neuromuscular activity, you can lead to respiratory failure, and ultimately more significant outcomes like more morbidity and death. And so you can see kind of on the right hand of each of these boxes, there are the more severe features. So this, respiratory compromise because of uncoordinated neuromuscular activity, those substantial bronchial secretions and bronchospasm, cardiac involvement, cardiac failure. Those are the ways in which a scorpion envenomated patient may ultimately succumb to their envenomation. And so, like some of the other envenomations we've talked about, there's grading scales for this. Grade 1 and 2 is really just pain and paresthesias, and the difference between that is whether or not it's local or is it kind of extended beyond just the site of envenomation. And then with grade 3 and grade 4, you're starting to get cranial nerve involvement because of those NMJ, the increased release of acetylcholine at the neuromuscular junction, or you're starting to see somatic and skeletal neuromuscular dysfunction. And so it's when you start to get that broader neuromuscular dysfunction, that's when these patients have kind of moved on to a more substantial and more morbid and potentially fatal version of their envenomations. And so, how do you manage these? Well, like a lot of the other envenomations we've talked about, that starts with just basic clinical supportive care. So, airway management, particularly for those who are dealing with dysfunctional breathing patterns, those who have substantial secretions, you may need to intubate those patients. If they are dealing with a huge amount of bronchospasm and bronchial secretions, then atropine is an important intervention, just the way it would be for an organophosphate or nerve agent. And then, as much as they need that IV sedation and analgesics for the neuromuscular agitation and pain. And then again, like a lot of these other envenomations, there is also an antidote available. So this is an FDA approved antidote, came through in 2011, and it is an equine Fab 2 antidote for the treatment of severe scorpion envenomations. These charts are taken directly from the New England Journal study that led to its eventual approval. And what you can see is it's a small study, but what you can see is on the left, this chart looks at the percentage of patients who had ongoing clinical abnormalities. And so you can see within 4 hours of enrollment, those who received antivenom had no persistent clinical abnormalities as compared to nearly all of those who were receiving placebo. And then ultimately, when you're looking at the amount of sedation that was required, well, with the placebo, that cumulative dose of midazolam went up and up and up between admission and discharge. Whereas those who received the antivenom, it's hard to tell if this is fully at zero, but it looks like it's pretty darn close. And so when they're receiving the antivenom, they get resolution of their symptoms quite rapidly, and their requirement for additional sedation is not nearly as much. However, like all of the other antivenoms, there is some degree of controversy that swirls around Anascorp. And the main controversy around Anascorp is that the vast majority of these patients do pretty well. I'll offer that it is a pretty unpleasant looking envenomation, and there are fatalities reported from this. And so it's maybe not quite got the same concern that the Black Widow antivenom had. However, the majority do quite well, and it is a really expensive antivenom. And so, generally speaking, what folks recommend is that there is a role for the antivenom. Anascorp certainly has a role. Again, it's FDA approved. And is a reasonable thing to give to somebody who's got really substantial clinical findings. The package insert does recommend starting with 3 vials. However, there are more recent clinical data that would suggest that there is a pretty similar efficacy or effectiveness if you're just doing vial by vial. So there are some efforts to try to keep down the total number of vials that you're administering to patients, because again, the majority of them will do quite well either way, and it is a really expensive antivenom. So keeping that total cost and that total volume delivered is probably a patient-centered intervention. And then we'll end with insects, and I think I'm probably coming close on time, so I'll try to cruise through this a little quicker. This is an overview of the insects we'll talk about. We'll talk about the vespids, which is the wasps, the apidae, which is the bees, and then we'll talk about the ants here in a second. So starting with the bees, the apidae are specifically the honeybees. The interesting part about them is that their stinger is connected to their guts, and so when they sting, they have these barbed stingers, and so when they sting, it will disembowel them, and so they can only sting once. Sad for them, maybe a win for us, hard to say. One thing to add on to the component or to the talk about the honeybees is that there is this Africanized honeybee that was initially introduced to Brazil and has migrated to around the United States southern border. And these have the tendency to do something that sounds utterly horrifying, which is these mass attacks. And it's been reported that it can include over 1,000 stings. So very different behavior than our native honeybees and potentially something more concerning. The bumblebees, conversely, they're able to deliver multiple stings, but both of these types of bees are generally pretty passive unless you mess with them. The vespids, such as the wasps, the hornets, the yellow jackets, these guys are more aggressive. They are also able to deliver multiple stings, and they are more likely to sting without significant provocation. And they live in or build nests in areas and in spaces that are more likely to have run-ins with humans, so nearer to human living areas. Clinical presentation, I imagine the majority of us are pretty well versed in what a bee sting or hornet sting feels like. There's pain, there's that local wheal and flare, and some localized edema. And the majority of these, when you're talking about just the venom, not the allergic component, but just the venom, do not have any systemic reaction. This bottom left component, again, this is referring specifically to the envenomation, not things like anaphylaxis. But you don't start to get those really severe stings until you started to string together, excuse me, multiple stings. And a scenario where, of course, you might see that is if with these Africanized honeybees, if you're getting above 500 stings, there is potential for fatality, even absent any anaphylactic component. Patients can have vomiting, diarrhea, hypotension, syncope, etc. So a lot of bad things, but it does take a lot of stings to get to this point. Of course, from an epidemiologic standpoint, from a public health standpoint, what is way more relevant to bee stings is less the venom and more, or the envenomation, more the allergic reaction. And I suspect the majority of us know what a bee or a hornet envenomation, or sorry, allergic reaction looks like. It's that urticaria, angioedema, bronchospasm, and shock for those who go untreated with epinephrine. So for the treatment, it's for the local pain, things like ice and local antihistamines and corticosteroids. The part that I think is maybe not completely intuitive amongst these otherwise probably more intuitive interventions is for the stinger removal for the honeybees. And so keeping in mind that these are the barbed stingers, I've seen mixed comments as to whether or not there is the chance to still have venom in the gland that's attached to the stinger. So some sources recommend using a credit card or scalpel, like I don't think incising, but kind of scraping away at it rather than directly pulling it because there's the chance to squeeze out more venom into the wound. Olson's specifically says that the chance that there's still venom left in the stinger is quite low, so you can probably pull it with tweezers as well. So where the truth lies, I'm not sure. Some discord there. And then, of course, if somebody's anaphylactic, you'll want to treat them with epinephrine. And then our last critter to go through for this talk is the fire ants. So these are spread across the southern United States. They sound terrifying. So they can repeatedly inject venom from this retractile stinger at the end of their abdomen, and they, on average, can deliver 7 to 8 stings in the circular pattern. And the comment in Olson's is that within seconds to minutes, you can receive thousands of stings with the accidental kind of intrusion into one of their dwellings. The pathophysiology, they, in a number of different ways, disrupt core cellular functions, things like disrupting the activity or the action of the sodium potassium ATPase, impairing mitochondrial respiration in a number of different ways, but they are locally cytotoxic, I think is the takeaway for their venom. The clinical manifestations, so they will manifest in these non-allergic reactions, and it starts with a lot of local pain and pustule formation. They start as a wheal and then eventually turn into these pustules. That's for the local reactions. It's the next category up is these large local reactions, which is painful, pruritic or itchy swelling that's above 5 centimeters in diameter. And then there are also those who can develop systemic reactions, signs and symptoms that are distal from the sting site itself. But the majority of these, it is the local reaction that is their only manifestation. And this image on the right, this is a couple of days after a guy I think was intentionally being bit or sorry stung by fire ants. And he's starting to develop these pustules. And there's some additional images from him, and you can see them start to turn all of these little whiteheads. These are not infectious, these are sterile pustules and not something that should prompt antibiotics. So, how do you treat these? It, more than anything else is pain control. So local wound care with cold compresses, clean it with soap and water. There's a recommendation in Goldfrank's, the textbook that we use for medical toxicology, that topical or injection lidocaine can be helpful as well as topical salt or vinegar mixtures for pain control purposes. For the bigger local reactions, you can talk about using oral medications like steroids, antihistamines, analgesics. And then if somebody is starting to develop major systemic reactions like signs or symptoms of shock, of course, it would be a very reasonable intervention to be thinking about sub-Q or IM epinephrine. I know that was a whirlwind and an awful lot of content. So thank you for bearing with me and getting through that lecture with me. I've got more to come, and it's a pleasure to do these with you all. And so looking forward to continuing on these review courses. Bye. Have a good day.